Hello, my name is Naval Daver. I'm a leukemia faculty in the Department of Leukemia at the MD Anderson Cancer Center in Houston, Texas. And today I will be discussing approaches to improve CAR T cell therapy in patients with acute myeloid leukemia. So, as many of you are familiar, CAR T therapy has been one of the most important and major breakthroughs in treatment of many different types of heme malignancies in the last decade, specifically in acute lymphoblastic leukemia and in diffuse large B cell lymphoma, as well as recently in mantle cell lymphoma. We have seen excellent activity and cure rates and remissions with the application of CAR T, even in heavily relapsed, multiply refractory patient populations. So, there is definitely a huge interest and a large amount of both preclinical and clinical research ongoing to try and optimize and develop CAR T cell therapies in the setting of other heme malignancies, specifically acute myeloid leukemia. The issue that we have had in acute myeloid leukemia with the development of CAR T cell therapy has been the identification of the ideal antigen. And so when we talk about the ideal antigen, whether it's for CAR T cell therapy, for antibody drug conjugate, or for bispecific antibody, the characteristics we're looking for is an antigen that is expressed very heavily on the leukemic cell and expressed minimally or not at all on the normal hematopoietic stem cells, progenitor cells, and normal healthy organ tissues like lung, cardiac tissue, liver, sinusoids, endothelium, and kidney. In addition, we also would like to have an antigen that targets not only the mature leukemic blast population that's in circulation in the bone marrow, but also the more primitive leukemic stem cells and pluripotent leukemic cells, because we know that if we only target the mature blast, eventually relapses will be driven by leukemic stem cell population. And the third thing is we would like to have an antigen that is expressed on 90 to 100% majority of the leukemia cells at a constant high level and is not lost over time if you target that antigen. And so this is really been the most important challenge in AML, where we have not been able to find that antigen. For example, in acute lymphoblastic leukemia, CD19 meets many of these criteria, and hence CD19 targeting CAR T cells have shown fantastic activity. In AML, the antigens that we have used have been CD33, CD123, CLEC12A, TIM3, and all of these have shown promiscuously where the antigen is expressed on the leukemic cells, yes, but also on many hematopoietic stem cells, normal pluripotent cells, as well as in endothelial, liver, or kidney. So what happens is when you try to target the leukemia cells with a potent load of CAR T cells, you start getting toxicities due to on-target but off leukemia effects. And so these can cause a lot of problems. And so going forward, our basic efforts have been to identify optimal antigens, and there's a lot of work looking at new antigens that may be identified through RNA sequencing as well as high throughput proteomic sequencing. In addition, we are trying clinical trials with different CAR T cells, including CD33, CD123, off the shelf, as well as autologous CAR T. There will be a new CAR T starting targeting CLL1, which appears to be a more promising and more specific marker in AML. And also, we are going to be looking at other approaches, such as using off switches to try and shut down CAR T cells if we see very prolonged toxicity, especially myelosuppression or cytokine release syndrome. And then a third approach may be to potentially use combinations of checkpoint inhibitors, either PD-1 or CD47 or others, to increase the longevity and the activity and block or avoid exhaustion of the CAR T cells. So these are many of the approaches. In addition to this, of course, we do want to do very in-depth biomarker analysis, pre-treatment, on treatment, which we're doing on most of the ongoing CAR Ts, to understand what are the changes in the antigen loss, mutations within antigens that could make them no longer susceptible to a particular CAR T, and changes in different immune checkpoint expression on the T cells that could lead to different pathways of resistance, which would give us more information in the pathway in the future in how to optimally combine or sequence different immune modalities with CAR T cells to optimize the outcomes in patients with AML. Thank you very much for listening.